There can be different sources of your pain. So it may be the knee, it may be the hip, maybe even be the back. So a physical therapist is trained to screen out for that. So I would consult a physical therapist that you trust and have them check you out.
Hey guys, thanks for watching our video. We're going to be talking about knee pain and different things that can cause it and what can we do about it. I'm Dr. Clementson. I'm a physical therapist out of Salt Lake Valley, and I work for Rocky Mountain Therapy Services.
Hi, I'm Jun. I live in Colorado Springs. I work in outpatient for Strive Physical Therapy.
My name's Casey Snell. I'm a physical therapist in the hospital setting. I work at Salt Lake Regional Medical Center, which is downtown Salt Lake, primarily focusing on inpatient, so post-surgery and that kind of thing. So let's get started. So yeah, like Brad said, we're going to dive into talking a little bit about some general knee pain. Why don't you start us off, Brad?
So when it comes to knee pain, there's a lot of things that we need to consider, right? And the patients that I see often are after surgery, or they've had this problem for a long time. So people, depending on where you live, people need to understand, can I go straight to a physical therapist? Do I have direct access? Or can I even bring that up? Can I talk to my doctor and say, instead of just taking pain medicine and seeing if my pain goes away, can we try to go to the root cause? And finding out what that root cause is, IT band or pes answering, maybe my quad is too tight. A super common one I see is actually the hamstring is super strong and the quad is super weak. So you have that ratio, that strength ratio is off. June, have you seen any of those? Do you treat people before surgery, or do you guys only see them after?
Absolutely. So conservative treatment, so that's physical therapy, can be effective and more cost efficient than going for surgery right away. So, and the other thing too is if you do have physical therapy beforehand, that can improve your outcomes for after your surgery as well. And the other thing too, kind of like Brad mentioned, is there can be different sources of your pain. So it may be the knee, it may be the hip, maybe even be the back. So a physical therapist is trained to screen out for that. So I would consult a physical therapist that you trust and have them check you out.
Jim brings up a good point. Being in that inpatient setting where I'm kind of seeing patients right out of surgery, we've had a few instances where a patient came, they had had surgery with another surgeon, things didn't quite go as smoothly as they hoped. They show up to our clinic, our surgeon operates on them, goes in, they had a hip surgery, they go in and the hip is totally fine, and so they do an x-ray and find out that the low back is just really messed up, and they never needed hip surgery to begin with. I mean, that's a malpractice suit waiting to happen. The surgeon actually made that comment. He's like, I'm not going to say anything, but if this patient wanted to. And so had they gone to, a trained professional like a physical therapist, like these guys are saying, they could have been screened. They could have ruled out that, hey, the hip is actually okay, and they've got some back pain and it's radiating down to the hip. That actually happens fairly common, I think. You guys would know better, but.
And if you look at the research, the orthopedic surgeons are the smartest that are out there. They know anatomy better than even physical therapists. We're right there. We're second. So they're brilliant. Don't distrust your orthopedic surgeon. But the hard thing is two things. First off, we're all human, so they make mistakes. And second, they have less time. A physical therapist, Jim, tell me if I'm wrong, but I spend about an hour to an hour and a half on the first visit, really figuring out what is wrong. And then we get the treatment going and we reassess what's going on. Whereas an orthopedic surgeon's like, okay, well, I've got an MRI and I've got a patient in pain and I've got 5 minutes or 10 minutes. Figure it out, fix the problem, right? Sometimes they don't have enough time to watch you walk or squat or move. And so it's like, okay, well, you hurt in your hip, let's do surgery there. And that's one of the what do they call that in PT school? They called it something about like the curse of treatment or failure. The biggest failure you can make in treatment is treating where the pain is. You guys remember hearing that?
Regional interdependence.
Yeah.
Yeah.
Regional interdependence. So it's like, boom, your hip hurts, let's cut open your hip. But then you find out there's nothing wrong. When I was on my first rotation as a physical therapy student, I actually had two patients, one on Monday, one on Friday. Both came in wheelchairs with 7 levels in their vertebrae fused together. They got their first back fusion when they were in their late 30s, each of them. By the way, they don't know each other and they're not related, but it was like deja vu. And they had 7 levels and over 70 plus grand spent on these surgeries. And the problem was actually their SI joint. They fused the whole back. The surgeons had their pain never left. And then the instructor said it's their SI joint. And within 2 weeks, their pain was gone. And they just spent the last 50 years getting surgeries in a wheelchair and no pain relief from their original problem because it was completely missed.
Mm-hmm. You brought up a good point there about the time spent too, because with physical therapy, we typically don't see patients for 1 or 2 visits, but we try to build up a program to where we can progress, our patient-specific exercises, stretches, and everything based off of, your individual needs. And so that's something that we kind of reassess as we go. So, maybe at first it is one thing that is causing or contributing. And then as we go further, it's kind of like peeling back the layers. As we kind of solve one thing, we can look at something else too. So just be patient with physical therapy and just keep working hard.
And I mean, of course, we want to advocate for our profession as physical therapists. But if you step back and look at how beneficial this is to you as a potential patient, we talk about conservative treatment and thinking about how not only how much money you could potentially save by going and trying conservative treatment first. And in fact, lots of orthopedic surgeons will recommend that. They'll suggest, hey, let's try going and seeing a therapist first. Try that for 6 weeks. If that doesn't work, then come back. I see that with several of the surgeons at our hospital. But like Brad was mentioning, direct care, you can go and see a physical therapist before you even go and see a surgeon. And money saved, potentially saving yourself pain and anguish of surgery. And then if you are screened by a therapist, they see, hey, you know what? Actually, I don't think this is something that I can help after seeing you for a few times. Then they will send you to the surgeon. And no harm, no foul. I mean, it's a pretty good way to go.
Well, and like June said earlier about that, he said your outcomes after surgery are going to be better if you got physical therapy first. They've shown that you put your body in better shape. You get your muscles more active, you get the tissues more pliable. Your recovery is actually faster and less painful after surgery if you did physical therapy first. And for some people, like if you're getting a total knee replacement, that can be for some people on their own. You don't necessarily have to work with a physical therapist to prehab, to do your pre-surgery stuff. Some people need that. They're like, I don't know what to work on, where I'm tight, where I'm weak, or I just don't know exercises. But some people, you go see your orthopedic surgeon and you get a program. You're like, I need this surgery. I've tried physical therapy, or maybe my knee's so jacked up there isn't hope. Then spend 30 days getting your quad, getting your glute to fire. You're getting the nerve and your muscle to talk to each other, creating a better chance for them to talk to each other after surgery.
So I want to ask a question to you guys. Being in the outpatient clinic, what would you guys say are maybe the top 3 most prominent causes of knee pain? Yeah.
That's a good question. June, I've got my answer. Do you want to go first or?
Go for it if you're ready.
Okay. So most common that I see is the IT band. Super common. People are confused because the IT band, a lot of people think it's more their hip or the side of their leg, but they always have pain in the side of the knee that wraps around towards the front from the outside in.
Side. Oh, outside. Okay.
Yeah, outside in. Another really common one is really tight adductor muscles. Those are the ones on the inside of your thigh and can be up close to the groin. Those muscles get really tight when our hips are weak, and so they'll pull on the knee. They cause genu valgum. That's where the knees collapse in. They cause pes anserine bursitis or tendonitis. That's where those tendons attach to the knee, and so it'll get really tender there. And then the last one is patellar tracking issues. So if your quad's too tight, if your maybe your quad is really weak in what's called the BMO, that's the inner portion. Sorry, the inner portion of the quad is too weak, and so the kneecap can pull sideways or just not track properly. Sometimes it's because you have the tissue, like the fascia and stuff, are too tight, and they'll want to do a surgery that's called a lateral release, which I strongly recommend not getting most of the time because it's not successful, but that's a tangent. Those are my three causes. What do you see, Jin?
Yeah, I do agree with everything you said, and I often see them in a combination as well. So, like you had mentioned, some issues with the patella. So again, the kneecap tracking. So whether what you're doing is, say, running, if it's squatting, walking, or even sitting for a long time, oftentimes the contributing factors can be multiple. Brad had talked about tight muscles like the adductors, the inner thigh. You could also have tightness through your calf. Your ankle and your knee joint work closely together. So, you know, if one is tight, the other one has to do a little bit more work. So kind of looking at joints above and below the knee. Again, Brad mentioned the hip. I also look at the ankle as well, and just kind of rehab both. You can also look at some different hip weakness as well. So the antagonist muscle to the adductors that Brad had mentioned are the hip abductors, which are the ones on the outside of the hips. Oftentimes when those are weak, that can put strain on the knees. So kind of looking at a combination of different things there. So yeah, I would say the patellofemoral issues, that I probably see the most, but also I do see some IT band issues as well. And then sometimes it's even I do see some times where it's like a back issue. So in order to compensate for back pain, people tend to load up their knee more. So kind of looking all around.
Yeah, definitely. And there's functional movement issues too. If you just squat poorly, but or a very physical job, working at a warehouse, and even if you lift properly, but you're just lifting too much, your body can break down.
Yeah. I mean, I think as physical therapists, we pride ourselves on being movement specialists. And that's one of the big benefits is you do 3 movements for us, and we can probably pretty quickly identify, okay, you know, when you squat, your knee comes in too far, your hip's doing this, your back's doing this. And right off the bat, we can probably point out several things. And I mean, talking about knee pain, at what point do you guys, or have you guys had much experience where you felt like, you know what, this is out of we've tried, we've done as much as we can with you, and it's just not going away? Have you guys experienced that much? Have you guys mostly just had success stories? And what do you do when you reach that point?
I only ever get people better. Wow.
You might say that.
No, I'm kidding. Yeah, definitely. It's right out of school. I graduated and I was like, I'm Superman. I fix everything. And it was humbling to realize. And I learned from some of my mentors, Paul Wortley, John Elmer, some of these mentors. I learned quickly that it's okay as physical therapists, if, you know, kind of on our side, if we can't fix everything. Sometimes surgery is needed. That's why we have it. Sometimes the damage is too much, or sometimes somebody that based on their lifestyle can't put in the work that's going to retrain their body to move properly, or they work at a warehouse and they can't take work off and they can't find another job, whatever it is. And so sometimes it's like, okay, we've tried, we've given this 2-3 weeks and we're not seeing the progress we want to. Or I had one patient come in with a spine, I feel like I refer more quickly. I had a patient come in with her neck, and I specialize in neck, and I was like, this is my thing. Okay, let's do this. And I look at her neck. I was like, nope, go see the spine specialist. I sent her over to Dr. Church, the best spine specialist there is in Salt Lake Valley. And I said, go talk to him. And he shot me a text that day, and he's like, dude, this patient owes you a beer. I don't drink, but I would have just given it to somebody else. But he was like, no, most PTs or most spine surgeons or whatever wouldn't refer quickly. Like, let's get people where they need to be. So it's okay to refer when needed.
Mm-hmm. Yeah, and I want to add to that again, we're not all perfect as physical therapists. And there are times when, yes, surgery is the most beneficial thing for the patient. But one thing that we can do kind of once we get up to that point where we realize that, hey, we've tried the conservative methods, let's, get you out for a consult. We can also educate on what to expect as far as things leading up to the surgery, the immediate what happens right after the surgery and kind of transitioning on from there. So a lot of times, that's a good time for us to be able to talk to our patients and say, hey, this, if you're looking at going the surgical route, let's prepare you the best we can right now. So it does definitely happen for sure.
And that's a perfect transition. On our next video, we're going to talk about how to prepare for surgery, what to do beforehand, what to expect in the hospital. And Casey will use all of his special expertise. Let us know what it's like there and what patients can do to have more success. If you've got any questions on what we've talked about, if you want to learn more, make sure that you go to your local physical therapist and learn more. But if you want to reach out to us, you can find me on my Facebook group. It's Dr. Brad Physical Therapy, or my YouTube, where this video is going to be posted, is Dr. Brad PT.